Let's understand the strategies in the implantation of an IOL in patients with a PCR. Here's a patient with a posterior polar cataract. Typically in polar cataracts, the rents that occur are as a result of some intraocular manipulation and often show up during the epinucleus removal. In this case, after removing the cortex and the epinucleus on the left side, you can see the classic elliptical spindle-shaped rent of a polar cataract. As I observe further, there seems to be no disturbance of the vitreous because the rent has retained its orientation. I perform a viscofluid exchange prior to removing the irrigation from the eye, and this dispersive viscoelastic will serve as a barrier to prevent any vitreous herniation from happening. I then swap hands and the rest of the cortex is removed by now introducing the aspiration from the left side. Note how the direction of the infusion is always towards the angle. The aim is to completely remove all the cortex from within the capsular bag despite the presence of this large rent and prevent any vitreous from herniating forwards. At the end of the cortex wash, once more I introduce some dispersive viscoelastic into the anterior chamber, after which we move to implanting 3-piece IOL. Whilst loading the IOL, it's always a good idea to look at the orientation of the leading haptic with respect to the nozzle prior to its introduction. So therefore, in this particular case, whilst I introduce the tip of the cartridge into the incision, I orient the entire cartridge injector system to the right to allow for the optimal orientation of the trailing haptic as it comes out of the cartridge. Let's now move to the IOL insertion. You always need to enlarge the incision to about 3.4 to 3.6 millimeters to allow for ease of insertion of a 3-piece IOL. Always ensure that the leading haptic is in its right position, and in this case, we want it to be in the ciliary sulcus. When we release the entire IOL, almost always the trailing haptic is outside the eye. Some more viscoelastic is inserted into the eye, and with the help of a Kugel hook hitched at the distal optic haptic junction, the trailing haptic is now rotated into its place, once more in the ciliary sulcus. The haptics are oriented typically at right angles to the rent to ensure its stability. What I'd like you to also note is that the rent has not enlarged in its size, signifying that there has been no disturbance of vitreous during the IOL implantation. At the end of the IOL implantation, note how I perform a posterior optic capture by virtually just pushing each end of the optic deep to the rhexis. After achieving a stable IOL in the ciliary sulcus, a careful visco wash is done to remove the visco from the anterior chamber, after which the wounds are hydrated, thereby bringing us to the end of the surgery. Let's now move to watching the second case. This too is a patient who presented to us with a soft posterior polar cataract, and as I impaled into the nucleus and brought it up, I noticed the presence of an underlying classic spindle-shaped rent in the posterior capsule. Note that we still have a significant part of the nucleus and epinucleus still in the capsular bag. Changing my settings to low flow settings, wherein I reduce the bottle height and the flow rate, I proceed with aspirating the nucleus and the epinucleus. Intermittently, it's not a bad idea to inject some dispersive viscoelastic whilst doing so. At the end of the nucleus management, a viscofluid exchange is performed prior to removing the phaco probe from the eye. Just like in the last case, I use a bimanual irrigation aspiration to remove the cortex. Let's now watch the rest of the cortex wash. At the end of the cortex wash, after performing a viscofluid exchange, looking closer, I noticed that the tear in the posterior capsule is incomplete. So what I plan to do now is introduce an intraocular forceps and convert this tear into a stable opening. Now I have a localized superior opening. Now with this localized opening in the posterior capsule, watch how I introduce a 3-piece IOL within the capsular bag. We have to ensure that the lower haptic goes within the capsular bag, after which, in a manner as described in the first case, the IOL is rotated into the capsular bag, after which, as you can see here, I'm performing an anterior optic capture. So haptics within the bag with the optic in front of the rhexis. With this, we come to the end of the second case. In this next case, while performing a hydrodissection, note in slow motion, I could see a pupillary snap. Now, even though that signifies a PC blowout, the nucleus management was uneventful. But notice towards the end of irrigation aspiration, I notice a peripheral tear in the posterior capsule. After introducing some viscoelastic, I now choose to implant a 3-piece IOL in the ciliary sulcus. Advancing the cartridge tip halfway into the anterior chamber allows for ease of insertion of the leading haptic. At this stage, I always introduce some viscoelastic into the anterior chamber prior to rotating the trailing haptic in the ciliary sulcus. At the end of the IOL implantation, note how I perform a posterior optic capture. This now brings us to the end of this case. Let's now move to watching the next case, wherein you will see, at the end of nucleus management, when I'm about to emulsify just a tiny bit of the residual epinucleus, what happens? I accidentally aspirate the posterior capsule. After releasing it, I can notice a large circumscribed tear in the posterior capsule. But this being a circumscribed circular tear, which is not going to extend at any point, I now choose under a dispersive viscoelastic cover to introduce a single-piece monofocal IOL in the capsular bag. The dispersive viscoelastic, as you know now, keeps the vitreous away and prevents any vitreous prolapse during this IOL insertion. And at the end of the case, this is what it looked like. A stable monofocal IOL in the bag and an unenlarged rent. Let's now move to watching the next surgery. We start with the stage of emulsifying the last fragment of this grade 2 to 3 nuclear sclerotic cataract. Whilst emulsifying this fragment, I suddenly notice a large opening in the posterior capsule under it. Most likely would have been an injury caused by the chopper. So how do I proceed from here? I've got a large rent, no apparent disturbed vitreous, and a retained fragment. So the first thing I do is introduce some dispersive viscoelastic in the anterior chamber. After which, with care and caution with low flow settings, this nuclear fragment is slowly downsized and emulsified. At the end of the nucleus management, once more I perform a viscofluid exchange prior to bringing the phaco probe out of the eye. Then with bimanual irrigation aspiration, the cortex is removed. As you can see, this is a fairly large rent, so the question of putting an IOL in the capsular bag does not arise. So what do we plan to do here? Once more under a dispersive viscoelastic cover, I now proceed to implant a 3-piece IOL in the ciliary sulcus, after which I perform a posterior optic capture and thereby having as an end result a very stable IOL in the ciliary sulcus. With this I come to the end of this video tutorial. Thank you.